few students I've actually reached out to, all trying to understand what the difference between a interventional pain fellowship is, a sports medicine fellowship, and a traditional pain medicine fellowship. So I want to try to get some clarity about these points. Before I go any further, I just want to let everyone know, this is just from my experience. Other people might have different thoughts or ideas about what these fellowships are and their own experiences. So I'm just trying to give it from my point of view, but hopefully it does help people out and allows people to make better decisions of what they're going for. I do not have much experience with doing these videos online in this format. So bear with me if I've been stumbling through or if there are audio or visual issues going through. But anyways, hopefully the content helps out. So I think the first and foremost, most important thing to look into is the difference between an ACGME accredited fellowship and a non-ACGME accredited fellowship. So the Accreditation Committee of Graduate Medical Education, that is the accrediting committee that helps make sure that programs are doing what they say they're going to do. They want to have certain standards, certain thresholds, make sure that there are certain didactic portions met, that there are certain milestones met, there are standards for the education process for fellowship. So the same ACGME that oversees the graduate medication of residency, they also oversee the fellowships. So these fellowships tend to be in bigger university programs. They also tend to be with academic programs and linked to universities and et cetera, et cetera. So that's one side of the coin. Typically, they have their own guidelines. They follow the guidelines based off of what their standards are and what they want to be out there. Versus a non-ACGME accredited, these tend to be more in private practice. They tend to be more group affiliated versus these university programs. And with this being said, that doesn't mean that there are not. I mean, there definitely are programs that are non-ACGME accredited that are associated to a university hospital. For example, Johns Hopkins has a non-ACGME accredited interventional spine fellowship. But they also have an ACGME accredited pain fellowship. So that's just something to keep in mind. And I'm sure there are other smaller programs out there that are accredited by the ACGME that aren't really linked to a big university or big center. So that's just something to keep in mind. Before going forward, explaining the difference between the different types of fellowships, I think it's important to pause here and think about, what future do you want? Typically, the ACGME accredited fellowships, those people that graduate tend to go to university programs. They tend to take on teaching roles. They also tend to work in bigger hospital systems. Now, that doesn't mean that you can't go into the private world or go into private practice, but from what I typically see is they tend to follow that role. These are the people that tend to enjoy doing research or have research a bigger part of their curriculum, so they continue on that trend. And again, the other side of the coin is on the non-ACGME accredited. These tend to be more private practice. They do a lot of research, but maybe not as enough that is almost as required by a university system would be. So a couple things there to keep in mind of what are your end goals? If you want to be more involved in research, it's typically better. It would make more sense to be involved in a university program with that ACGME accreditation. If you don't have such a desire for research and you don't want to keep it as a bigger part of your practice, then you'd probably be fine not going into that program. A big thing, or non-ACGME accredited program. So a big thing that I do want to bring to people's attention is University and some universities, actually many, and many hospital systems will not allow you to do certain procedures, even if you're fellowship trained, if you went to a non-ACGME accredited fellowship. So I'll give you an example to make this make more sense to you for you. The Ohio State University here in Columbus will not allow me to do fluoroscopy guided procedures because I did not go to an ACGME accredited fellowship. They say you must go to an ACGME pain accredited fellowship to be able to do those procedures at their facilities. So that's just something to keep in mind. There's lots and lots of examples out there of this out there. Another thing to keep in mind is certain states will require you to have a pain board and be pain board certified to do these pain procedures in the hospital, in their hospital. Now, this varies state by state, but there are boards that will not allow you to sit unless you went for an ACGME accredited fellowship. So we'll give myself as an example. If I wanted to take the American Board of Physical Medicine Rehabilitation Pain Fellowship, as far as I know, as I could not sit for that board exam because I did not go to an ACGME accredited fellowship. There are ways around this. There are boards out there that you can do. The American Board of Interventional Pain Physicians is an example of a board that I could sit for. And there's one other board out there that another pain board out there that we would be able to take. And there's just different board accreditations. So that's something else to keep in mind. If you have a desire to work in a hospital system, in a big university system, you might be better off considering going to an ACGME accredited fellowship for that reason. I do have some notes here, so that's why I keep looking down. I'm just using it to keep my thoughts organized. Hopefully it's flowing appropriately for you. And again, these are questions that I've been asked over the past few months, at least 1 or 2 times a month. And ever since I wanted to go into this field when I found out in residency. So I'm sure a lot of questions have come up for you guys. So hopefully this is progressing forward for you and making some sense. So another concept about the ACGME accredited fellowships, you do have to do your research duties. There are going to be certain academic benchmarks you have to hit, such as different didactic lectures, I don't remember them all anymore, unfortunately, but I think the core competencies, you do have to be mindful of the duty hours. I don't know how much it comes into fellows. So that's something to keep in mind. As far as the private practice, you're hoping you go into a spot that, when I say private practice, I mean non-ACGME accredited fellowship. The term should not be used interchangeably. You would hope that you have a good didactics in that program. You would hope that they have some sort of research, and you would hope that there is some sort of limitations on how many hours you're working, but there's no regulating committee to really oversee this. So that's just something to keep in mind. Okay, so let's move on to talk about, the difference between a sports medicine fellowship, a pain fellowship, and an interventional pain fellowship. Interventional pain, sports and spine, I should say. So a couple things. First, I should say that the ACGME accreditation, there is sports medicine that are ACGME accredited and non-ACGME accredited. There are pain fellowships that are ACGME accredited and non-ACGME accredited. You get the point. So just keep that in mind. I don't know of very many interventional spine and musculoskeletal health fellowships that are ACGME accredited. So do keep that in mind. There might be out there. And I want to give a little bit of backstory of this before I go into it. In the past, there were pain medicine fellowships that were kind of overseen by the anesthesia department, but also overseen by the physical medicine and rehabilitation department. As the years went on, they realized, hey, we don't really need 2 different types of pain medicine. Let's just get rid of one and hang on to the other. And they kind of held on to the anesthesiologist overseeing it, anesthesiologist, pain medicine overseeing it. Now, in the past few years, there's been a big push for the physical medicine rehabilitation owned programs. So there are more of those popping up across the United States. It's great work. A big push from the program director over in Vanderbilt, who was kind of heading up the charge for that. So now there are more spots that are opening up for physical medicine rehabilitation residents to go into a pain medicine fellowship that's overseen by the PM&R department of a hospital or a university system. So that's something to just keep in mind as well. Now, so I like to think of this as a spectrum of having a sports medicine fellowship on one end, and then a pain medicine fellowship on the other end, and then having the interventional sports and spine in the middle. So a sports medicine fellowship, in all intents and purposes, is doing a lot of sports medicine. We'll call it just that. You're doing a lot of injury prevention, injury recovery, getting athletes and just even the general population back to doing activities they love to do. If you do choose this kind of fellowship, you'll be great with the ultrasound. You do get lots and lots of sports coverage. You get training tables where you're working with athletes. You get, sideline coverage, which a lot of people do love. There's tons of other pros. You'll be an expert of the musculoskeletal health system. You'll understand traumatic brain injury and non-traumatic brain injury and concussions and subconcussive hits. You'll understand diet, nutrition, really training protocols, and much, much more. I'm not even scratching the surface of what it can all do. The other cool thing is if you're interested in platelet-rich plasma or bone marrow aspiration or fat aspiration injections for healing and recovery, this would kind of be the best area to really explore those options as the research and data keeps coming out. The American Medical Society of Sports Medicine throws one of the better conferences yearly. I've attended a couple and I've had a great time every time I've gone to them. So lots and lots of great people, get to meet different breadths of disciplines, from family medicine to physical medicine and rehabilitation to emergency medicine and orthopedic surgery. And it's great. So some of the cons about the sports medicine fellowship, and I'm not sure if this is much of a con or as my personal bias, is, in my opinion, a physical medicine and rehabilitation residency is essentially sports medicine as far as the clinic's concerned. Now, I don't want to talk about silent coverage and all that other stuff. I'll get to that in a minute. But as far as clinic's concerned, that's the exact same patients that I was seeing in my residency in clinic was the exact same stuff I was seeing in the sports medicine clinic. So it wasn't really beneficial for me to go do another year fellowship of seeing the same stuff I've seen for 3 years in residency, plus the intern year when I did physical medicine rehabilitation rotations and spent a lot of time in the family medicine clinic, sports medicine clinic, because that was my interest. The other cool thing about the physical medicine rehabilitation residencies is you get lots and lots of ultrasound exposure. I can honestly say that it wasn't enough. I know that my sports medicine colleagues will blow me out of the water with their ultrasound techniques and skills that they develop over that year. So that's just something to keep in mind. I'm not going to say my skills are terrible. I think they're pretty good, especially especially considering how often I do injections and I'm still going to courses and I'm still learning. But these individuals, my colleagues in the sports medicine world, they're the ones teaching these conferences or courses, and I'm the one that's attending them. So that's something to keep in mind if that's where your interests are. Another disadvantage is you really won't get the exposure to interventional pain procedures, epidural pain blocks, spinal cord stimulators, facet blocks, radio frequency ablations, et cetera, et cetera. You may get some exposure. When I was interviewing for sports medicine or inquiring about interviewing for sports medicine fellowships, I asked questions about this, and they said, yeah, we can give you a month. You might get, 10, 50, 60 procedures in that month with the pain doctor. But that's about all we can offer. It's like, okay, well, that's great to know, but to be really competent in these interventional procedures, you really need hundreds and hundreds, if not thousands and thousands of cases. I did 15 months of fellowship, and I had, around 3,000 cases either I saw or scrubbed in or did myself over my course of my fellowship, and I still didn't feel adequately prepared. I still go to conferences. I still go to training courses to learn more. So that's just something that said, if you really have interest in doing these interventional pain procedures, the sports medicine fellowship probably won't be adequate enough for you. And these aren't things you can go learn on a weekend course. You really need the foundation at the beginning, and then you build up on that as the years go on. The other thing for me was I didn't really necessarily want to go do all that sideline coverage. Certain sports I love, other sports I don't love. I didn't really want to go watch a JV college basketball game on a Thursday night when I had to wake up the next morning for 7 a.m. clinic. That wasn't for me. That's not where my head was or my heart was. So that was a big reason why I didn't want to go to sports medicine coverage. Other people say they will swallow that pill because then they get to go to the, pro teams sideline coverage, during their fellowship. And I get it. That's a big trade-off. And if that's what you want to do, that's awesome, and more power to you. So let's talk about the other side of the spectrum where we go into pain medicine, ACGME accredited fellowships, or just pain medicine fellowships. Because a lot of these are ACGME accredited, I'm going to talk about it generally in that sense first. So the ACGME has requirements for these programs where you need to do some psychiatry or psychology training, rotation, or addiction training, rotation. You also have to know how to manage airway. You might have other pain blocks, perioperative training, and you also have some medication management. Now, from what I've heard, these rules aren't so hard and fast anymore, and they've kind of gone away from some of these traditional things. Airway management is definitely very vital to know and very important to understand. But I'm not sure as much about the psych and addiction medicine anymore, or opioid or chronic pain treatment. I'm sure it's out there. I just don't know enough, and I've heard different varying stories from different people. Another thing is, you will get to see a lot of procedures. A lot of times the procedures are functioning on actually just blocking pain. Sometimes in these realms, they overlook what's causing the functional pain, or thinking outside the box. And that's something, we learn heavily in physical medicine rehabilitation, and in the interventional spine world and MSK world, we do think a lot more about function. With that being said, a lot of this is kind of being meshed together. I don't think there's one way or another as much anymore. I think we're learning from each other, and we're growing on each other's ideas, and we're collaborating a lot more. So in the ACGME accredited pain fellowships, you're focusing a lot on pain blocks, nerve blocks in the different parts of the body, especially perioperatively, a lot of neuromodulation with spinal cord stimulators or peripheral nerve stimulators. You'll also get a lot of, you would probably get a lot of, you may get a lot of exposure to pain pumps and managing pain pumps as well. As far as non-ACGME accredited pain fellowships, there are plenty out there. I know of at least 4 or 5 or 6 in the eastern states. Some of them have a lot more opioid prescription and a lot more opioid management. Other ones have very little. So it just varies. Because it's not overseen by any accrediting committee or anything like that, it's really hard to say what each individual one does. One of the cons about these pain fellowships, especially in the hospital centers, you're really spreading yourself thin through tons of different departments. So you may not get the higher number of procedures that you would like to in these fellowships. There's an example when I was rotating and when I was interviewing for pain medicine, interventional spine, and I was over talking with my pain medicine colleagues. They were telling me their numbers, and there seemed to be much lower than what I would get exposed to at the interventional spine and musculoskeletal health fellowships. I also think that this might have just been a small sample size because I hear of different programs having a lot different standards. So I can't speak 100% confidently about that, but I just know at least those one or two examples that my colleagues told me comparatively to what I had exposure to in fellowship. Something to just keep in mind. Let me think what else. That's all I can really say about the pain fellowship right now. Like I said, now they are being housed under the anesthesia groups and the physical medicine rehabilitation groups. I think that's awesome. In residency, my physical medicine rehabilitation residency, we went over all of our MRIs in detail. We checked out all the lumbar spine MRIs, especially. And it's very funny because nowadays, all the stuff that our program director was talking to us about in fellowship and residency, it's now what the pain medicine doctors are talking about at the big conferences across the United States with multifidi, atrophy, or facet fluid, or micromotion at the at a functional spinal unit. So it's just funny to me that we were talking about this 4 or 5 years ago in residency, and now everyone's like, oh my gosh, this is amazing. So I just think this isn't to downplay anyone or any training. It's just sometimes that's not what the focus of the training is, and it was our focus of training. So just find it something that was interesting to me. And who knows, 5 years from now we're going to be talking about stuff that you guys learned in residency that I never knew. So I'm not, I definitely don't want to say that, oh my God, I'm the smartest person in the world, but it's like, this is the reality of things. Things constantly evolve, and you constantly grow on ideas that you might have not thought were important back in residency or med school, but they start to become more important over time. So the Interventional Spine and Musculoskeletal Health Fellowships. So again, most of these are non-ACMG accredited. The North American Spine Society, bound together with the powers of Dr. Furman and a few other physicians, and they're like, hey, we want to make another accrediting committee. We want to oversee it. We want to give our fellows certificates to prove that they're competent. They've done at least this amount of work, and we have our higher standard, et cetera, et cetera. So the North American Spine Society, who does house more surgeons as well as interventional physicians, they started becoming an oversighting committee for the North American, or the NAS accredited fellowships is what I call it. So there are a handful out there. You can go to their website and check them out. That is one of the programs that I graduated from. I graduated from Birmingham, Alabama, with Goodman, Dr. Goodman and Dr. Malampati. So the reason I talk about that spectrum is because I feel like this falls somewhere in the middle. We did a lot of sports medicine type of injuries, tendinopathies, tendinitis, rotator cuffs, hips, knees, ankles, whatever. We kind of saw those as they came in, and we did certain types of intervention for them, whether it be injection or nerve block or something along those lines. We also did a lot of interventional stuff. We did a lot of epidurals. We did a lot of facet joint blocks. Right now the government isn't paying for the facet joint blocks as much anymore, and they really want us to do medial branch blocks. that's a conversation for a different day. Just want to put that out there. But, you know, we did a lot of vertiflex procedures. If you're familiar with that, what that is, it's an interspinous spacer procedure. We did a handful of neuromodulation and spinal cord stimulators, not nearly as much as our colleagues in the pain medicine world did, but we did do a handful. We didn't really do any pain pumps. We did absolutely zero opioid management. So we really covered our bases with pain, sports medicine, and pain medicine. Not nearly as much as either one would get, but we're getting at least a good exposure to both. And then for us, we also did EMGs, kind of help cover our bases. The cons are, I guess, just that, like, you know, if you want to go work at a university or hospital system, you might have a hard time. And if you go to one of those states that require a pain board, you might have a hard time. So just keep that in mind in the long run for you. You know, that's all I really need to say about that interventional spine. There's a lot more topics I want to talk about. And one thing I do want to talk about is, you know, these fellowships in themselves, 1 year, even 15, 16, 17 months, it probably isn't enough. In my opinion, we would really need 2 full years of fellowship. 1 year of just the base interventional stuff and ultrasound training, and then the second year of the advanced surgical stuff of making pockets for the implants and the batteries of the spinal cord stimulators, or some of the more advanced procedures that we do, like kyphoplasties as well, and that kind of stuff, just because it really needs that technical skill. I could even make an argument that you really need a full residency for this kind of stuff, and then a 1 year fellowship added on, between reading musculoskeletal ultrasound, reading musculoskeletal MRIs, navigating through the payer systems, navigating through, you know, really understanding what pain is in the psychological field, in the psychiatry field. I could probably off the top of my head make a curriculum for, you know, 4 years for this, but, you know, that's a conversation for another day. I just want to, you know, bring this to people's attention, because I really do appreciate what the MedEd Combine is doing. If you don't know what that is, go check them out. Dr. Jafrida, Dr. Ostrogi, Dr. Stevens, they do these every quarter training programs for understanding new devices and new equipment that are coming out. You learn about them online, and then you go, if it's something that you feel like you want to do after your fellowship, you go out and train in that modality, you train in that device. And it's a great setup, and I love what they're doing. I think it's really expanding the field. They just had their first big in-person event where they accredited even fellows for 3 separate devices, which is absolutely huge, because if you're accredited and get certified before you leave fellowship, then whatever job you go to, you have that opportunity to present that to them. Now, something should be said about that is, you know, not every job out there is going to want you to do a lot of these things. They might hold you to your corner. That's another conversation for another day, but just want to kind of let you guys know, it's like cool to learn all these stuff, but if you go to a job where you're kind of boxed out by either the hospital or by the partners in the system, you may not be able to do what you want to do. But you can also find ways to make it work. So just keep that in mind. And then there's another American Society of Pain and Neuroscience, Dawood Syed, Tim Deere, Stephen Fulowski. They also have lots of hands-on courses throughout the year. They really invite the fellows. They really want them in there, getting their hands on, asking questions. So that's another one that's really important to keep your eyes out for, if that's something that interests you. NANS, North American Neuromodulation Society. I think that's what it stands for. I can't remember off the top of my head. And then the PSPS, they also have hands-on courses for fellows and residents. So those are lots of hands-on courses. And I think there's a few other ones out there, Eastern Pain Society, Eastern Pain Association. There's several out there, but those are some of the bigger ones. I just love what they're doing, because it really gets your hands on. get you back in exposure. Exposure is key. The more confident you become with these procedures, the more competent you become in these procedures, the more likely you are to take this to someone and be able to use it. I kind of talked about this. Dr. Jafrida and I will hopefully be talking on a podcast and on the YouTube here shortly in the next few months and talk about, where this field is going and what this interventional spine field is and where we think it could go in the future. We're good friends. We talk all the time, bounce ideas off each other. Part of one of the mastermind groups, as I call it, that I'm a part of. So it's really cool to have someone that's been out in the field a couple of years ahead of me to talk to these things about. Let's see. And those are the main points that I have. I think to wrap it all up, I think the most important thing is, really decide what you're looking for out of a fellowship. Try to navigate what kind of field you want to be working in. If you want to be private practice, if you want to be in an academic program, if you want to be working with residents and fellows and students. And, do you want a big research requirement? Do you not? And there's no right or wrong answer. Everyone's a little bit different. Monetarily, there'd be differences as well. The big thing, if you're looking into it, you can only pick two of the three things, either location, the work-life balance, or the pay. So pick the two that are most important to you and stick to it. You can get all three, but it kind of gets diluted down a little bit. So just keep that in mind. Anyways, I hope that you guys found this useful. If you have questions, feel free to drop a comment in the comment section here. Reach out to me on Instagram or Twitter or LinkedIn. I'm happy to engage. If you find this useful, let me know. I can do more of these solo episodes. I plan on doing more of these solo episodes. So let me know what you have interest in talking about or hearing about. I'm also planning on talking to a lot of people in the interventional spine and musculoskeletal world, a lot of pain medicine doctors, a lot of physical medicine and rehabilitation doctors. I have a plethora of people lined up that have agreed to doing a podcast with me. So I'm hoping that we'll get that going in the next few months. And we'll keep engaged and keep growing. So everyone have a good evening, and I hope to talk to you soon.